Hi, I'm Dr. Chris Lewis, one of the chief educators here at Doctors in Training, and I want to welcome you to another solid anatomy lecture, and this one's on the leg and ankle. In this lecture, we'll discuss the features of the tibia and the fibula, the ankle joint, ligaments, muscles, compartments, and blood supply of the leg, and the popliteal fossa. Now, I'll be back later with some clinical correlations and the end of session quiz. But for now, I'm going to turn it over to our primary lecturer, Dr. John Phelan.
When you're out on the street collecting cans and bottles, or in the supermarket shoplifting scallions, you'll hear the common folk referring to the entire lower extremity as the leg. After watching this solid anatomy lecture on the leg and the ankle joint, it's going to take every fiber of your being to resist the urge to correct them, because you're about to learn, among other things, that the leg is just the portion of the lower extremity found between the knee and the ankle joint. The bones of the leg are the tibia and fibula. They are connected by an interosseous membrane that spans the length of the medial edges of the bones and by the four tibiofibular ligaments, which are found at the distal and proximal ends of the bones and are named anterior superior, posterior superior, anterior inferior, and posterior inferior. If you hear of someone sustaining a high ankle sprain, they really haven't damaged their ankle joint. They've sprained their inferior tibiofibular ligaments and occasionally their distal interosseous membrane. The proximal end of the tibia has a pair of condyles that articulate with the femoral condyles to form the knee joint, as you may recall from the solid anatomy lecture on the knee. These condyles are found on the tibial plateau, which is the broad superior end of the tibia. On the anterior side of the proximal tibia is the tibial tuberosity for attachment of the patellar ligament. On the medial side of its distal end is the medial malleolus. The proximal end of the fibula is the head. Inferior to it are the neck and the body or shaft. At the distal end of the lateral side of the fibula is the lateral malleolus. The pronunciations I'm using for malleolus and malleoli may sound strange to you. They certainly sounded strange to me the first time I heard an orthopedic surgeon pronounce them that way, but it turns out that that's the correct pronunciation. The common pronunciations, malleolus and malleoli, are incorrect. The correct pronunciation, again, is malleolus, which is singular, and malleoli, which is plural. The tibia is the weight-bearing bone of the leg. The fibula does not bear weight, but it does serve as an attachment point for ligaments of the knee and the ankle, and for a few muscles as well.
It's time for a clinical correlation. Let's get going. Now, before we move on to discussing the ankle joint, I want to bring up a clinically important landmark just discussed, the tibial tuberosity. Now, the tibial tuberosity is the point where the patellar ligament attaches onto the tibia. So the quadriceps muscle gives off the quadriceps tendon, which attaches to the patella, and then the patella attaches to the patellar ligament, and then that patellar ligament attaches to the tibial tuberosity. So a lot of connections there. Now, the reason why this is an important landmark clinically is that repetitive stress to this area of attachment can result in pain, and we call this Osgood-Schlatter disease, or sometimes we refer to this as osteochondrosis of the tibial tuberosity. Now, we see this primarily in 11 to 13-year-old boys, and more specifically, 11 to 13-year-old athletes. This is because athletes put repetitive stress on this area, and at this point in their lives, there is an accelerated growth taking place, causing the quadriceps to pull on the tuberosity. So that's going to end up answering our two questions here. Osgood-Schlatter disease is the associated disease with pain over the tibial tuberosity, and it normally occurs in 11 to 13-year-old athletic boys. All right, guys, let's get back to that lecture now.
The ankle joint is the area of articulation between the distal ends of the tibia and fibula and the superior end of the talus. The surfaces of the bones involved in the ankle joint are covered by hyaline cartilage. The ankle joint is a synovial, hinge-type, uniaxial joint. The two motions about the ankle joint are plantar flexion and dorsiflexion. There are several joints among the tarsal bones that we will collectively refer to as the intertarsal joints. The intertarsal joints allow two motions, inversion and eversion. Inversion involves lifting the medial edge of the foot, while eversion involves lifting the lateral edge of the foot. Be aware that these are not motions of the ankle joint. They are motions of the intertarsal joints. A handy mnemonic to use to remember the difference between inversion and eversion is mile, M-I-L-E. If the medial edge of the foot is elevated, M, the intertarsal joints are being inverted, I. If the lateral edge of the foot is elevated, L, the intertarsal joints are being everted, E. M-I-L-E, mile. These actions are sometimes described as inversion and eversion of the foot. There are three ligaments on the lateral side of the ankle that hold the joint together. The calcaneofibular ligament runs from the calcaneus to the lateral malleolus, which is the distal end of the fibula. The anterior talofibular ligament, running from, again, the lateral malleolus to the anterior side of the talus, and the posterior talofibular ligament, which runs from the lateral malleolus posteriorly to the posterior side of the talus. On the medial side of the ankle joint, there are several ligaments running from the medial malleolus, which is the distal end of the tibia, to various tarsal bones in the foot. These ligaments are collectively referred to as the deltoid ligament. So it's correct to say that the ligament of the medial side of the ankle joint is the deltoid ligament. Even though inversion and eversion are not ankle joint movements, ligaments of the ankle joint limit these motions and may become damaged upon hyperinversion or hypereversion. Excessive inversion of the intertarsal joints puts stress on the ligaments of the lateral side of the ankle joint, namely the calcaneofibular ligament, the anterior talofibular ligament, and the posterior talofibular ligament. Excessive eversion of the intertarsal joints puts stress on the ligaments of the medial side of the ankle joint, which again are collectively referred to as the deltoid ligament.
Okay, we're back again for another clinical correlation. Let's spend a little time talking about ankle injuries. Now, the ankle is the most frequently injured major joint in the body. Ankle sprains, or this is when you say sprains, we're actually talking about torn fibers of ligaments, are the most common. Now, a sprained ankle is nearly always from an inversion injury. So this is involving twisting of the weight-bearing plantar flexed foot. Now, it is more difficult to have an eversion injury, and the majority of these ankle sprains that you'll see will be from that inverting of the foot. Now, the anterior talofibular ligament, and this is part of the lateral ligament, is most commonly torn during an ankle sprain, either partially or completely, resulting in instability of the ankle joint. The calcaneofibular ligament may also be torn as well. All right, let's hit a couple questions here. Which type of injury is more common with an ankle sprain, inversion or eversion? Easy, that's inversion. Next question, which ankle ligament would most likely be injured in an inversion injury of the foot? That's going to be your anterior talofibular ligament, and then the next one is going to be your calcaneofibular ligament. All right, so let's talk about the different compartments of the leg and get back to that lecture.
The muscles that act on the ankle and intertarsal joints are found in the leg. The deep fascia of the leg is the crural fascia, which is the name that the fascia lata of the thigh changes to when it crosses inferior to the knee. The crural fascia the interosseous membrane, and the tibia and fibula combine to divide the leg into three compartments. There is an anterior compartment, anterior to the interosseous membrane, a posterior compartment, posterior to the interosseous membrane, and a lateral compartment that is lateral to the fibula. A separate motor nerve innervates each compartment of the leg, but all three of those motor nerves are derived from the sciatic nerve. Recall from the solid anatomy lecture on the thigh that the sciatic nerve, which is a branch of the sacral plexus of nerves, has two divisions that physically separate from each other in the vicinity of the popliteal fossa. The tibial division continues inferiorly from the popliteal fossa to enter the posterior compartment of the leg, where it innervates all of the muscles occupying that compartment. The common peroneal division travels inferolaterally, crosses the knee, and passes to the lateral side of the fibula at the level of its neck. At the posterior border of the neck of the fibula, the common peroneal nerve is between skin and bone with no muscle intervening to cushion it, and is thus very vulnerable to injury at that point. Be aware that the Greek-derived word peroneal and the Latin-derived word fibular are synonymous. Fibular is used most often by anatomists and is seen most often in anatomy textbooks and atlases, but peroneal is used clinically, so we'll be using peroneal during this lecture. The common peroneal nerve dives under the muscles of the lateral compartment, the peroneus longus and peroneus brevis, and divides into a superficial peroneal nerve and a deep peroneal nerve. The superficial peroneal nerve innervates the muscles of the lateral compartment of the leg, while the deep peroneal nerve innervates the muscles of the anterior compartment of the leg. The anterior compartment of the leg is occupied by four muscles. The tibialis anterior is the largest and most medial. It originates from the lateral condyle and superior half of the lateral surface of the tibia and the interosseous membrane. Its distal tendon crosses the ankle joint and runs on the medial edge of the foot to insert on the medial side of the base of the first metatarsal. The tibialis anterior dorsiflexes the ankle joint and is an inverter of the intertarsal joints. Lateral to the tibialis anterior is the extensor hallucis longus. You may recall from the solid anatomy lecture on the hand that the fancy anatomical word for the thumb is pollex. The original Greek anatomists named the first digit on the foot the hallux. The extensor hallucis longus takes its origin from the middle part of the anterior surface of the fibula and the interosseous membrane. It runs inferomedially to cross the ankle and inserts on the dorsal aspect of the distal phalanx of the hallux. As you may have guessed from its name, it extends the hallux. It also dorsiflexes the ankle joint and is a weak inverter of the intertarsal joints. Lateral to the extensor hallucis longus is the extensor digitorum longus, which originates from the lateral condyle of the femur, the interosseous membrane, and the medial surface of the fibula. It runs inferolaterally, crosses the ankle, and gives off four tendons that insert on the middle and distal phalanges of the lateral four digits. The extensor digitorum longus extends the lateral four digits, dorsiflexes the ankle joint, and is a weak everter of the intertarsal joints. The peroneus tertius appears to be part of the extensor digitorum longus, but its tendon does not insert on a phalanx, it inserts on the shaft of the fifth metatarsal. Its official origin is the inferior part of the anterior surface of the fibula and the interosseous membrane. It dorsiflexes the ankle joint and everts the intertarsal joints, but it has no action on the digits. The peroneus tertius muscle is absent in about 17% of limbs. It may be absent unilaterally or bilaterally in any given individual. Remember that all of the muscles of the anterior compartment of the leg are innervated by the deep peroneal nerve, and they are all dorsiflexors of the ankle joint. The medial two muscles are inverters of the intertarsal joint, and the lateral two muscles of the anterior compartment are everters of the intertarsal joints. The lateral compartment of the leg, which is just the small area lateral to the fibula, contains only two muscles, the peroneus longus and the peroneus brevis. Remember that these muscles are usually called the fibularis longus and fibularis brevis in the textbooks. The peroneus longus originates on the lateral part of the head and proximal shaft of the fibula. Its distal tendon passes posterior to the lateral malleolus, and it crosses onto the plantar surface of the foot. The tendon traverses the foot and inserts on the lateral side of the head of the first metatarsal, opposite to the insertion of the tibialis anterior, which it opposes. That is, it is an everter, while the tibialis anterior is an inverter. The peroneus brevis also originates from the lateral side of the shaft of the fibula, but inferior to the origin of the peroneus longus. Its distal tendon also passes posterior to the lateral malleolus, but instead of crossing onto the plantar surface of the foot, it inserts on the base of the fifth metatarsal. Both the peroneus longus and peroneus brevis use the lateral malleolus as a pulley to plantar flex the ankle joint. Both of these muscles also evert the intertarsal joints. Remember that both of these muscles are innervated by the superficial peroneal nerve. Remember also that the peroneus tertius muscle is not in the lateral compartment. It's an occupant of the anterior compartment, and it's innervated by the deep peroneal nerve. The posterior compartment of the leg, which is posterior to the interosseous membrane, contains 8 muscles. The largest are the medial and lateral heads of the gastrocnemius, which take their origin from the distal femur, cross the knee joint, and insert on the tuber calcaneae, which is the posterior part of the calcaneus, via the tendocalcaneus, or the Achilles tendon. Also using the tendocalcaneus as its insertion tendon is the soleus, a broad, flat muscle that is named for its resemblance to the sole of a sandal. Soleus is Latin for sandal. Unlike the gastrocnemius, the soleus does not cross the knee joint. It originates from the posterior aspect of the tibia along an eminence called the soleal line, and from the head of the fibula. The gastrocnemius flexes the knee joint and plantar flexes the ankle joint, while the soleus just plantar flexes the ankle joint. These muscles merge distally and are occasionally referred to as a unit, the triceps surae. The plantaris muscle has a very small muscle belly and a very long tendon. It originates on the inferior end of the lateral condyle of the femur, crosses the knee, runs inferolaterally down the leg, and inserts on the tuber calcaneae, independent of the Achilles tendon. The plantaris flexes the knee and plantar flexes the ankle joint. It's absent in about 10% of limbs and may be absent unilaterally or bilaterally in any given individual. The popliteus muscle is found just superior to the soleus. It originates on the lateral surface of the lateral condyle of the femur, passes between the fibular collateral ligament and the lateral meniscus, forms the floor of the popliteal fossa, and inserts on the posterior surface of the tibia superior to the soleal line. It flexes the knee and medially rotates the knee by medially rotating the tibia with respect to the femur. If you've watched the solid anatomy lecture on the knee, you may recall that the popliteus muscle unlocks the knee. Deep to the soleus are 3 more muscles in the posterior compartment of the leg. They are, from lateral to medial, the flexor hallucis longus, the tibialis posterior, and the flexor digitorum longus. The flexor hallucis longus originates from the posterior surface of the fibula and the interosseous membrane, runs inferomedially, and passes posterior to the medial malleolus. The tibialis posterior originates from the posterior surfaces of the tibia and the fibula and the interosseous membrane. The flexor digitorum longus originates from the medial part of the tibia and from the fibula. All 3 of these muscles run inferomedially, pass posterior to the medial malleolus, and cross onto the plantar surface of the foot. The flexor hallucis longus inserts on the distal phalanx of the hallux. The flexor digitorum longus generates 4 tendons that insert on the distal phalanges of the lateral 4 digits, and the tibialis posterior inserts on various tarsal and metatarsal bones. All 3 of these muscles use the medial malleolus as a pulley to plantar flex the ankle joint. They all tend to elevate the medial edge of the foot, so they are all inverters of the intertarsal joints. Additionally, the flexor hallucis longus flexes the hallux, the flexor digitorum longus flexes the lateral 4 digits, and the tibialis posterior has no effect at all on the digits. At the level of the medial malleolus, the order from anterior to posterior of these latter 3 muscles may be remembered by the mnemonic Tom, Dick, and Harry. T for tibialis posterior, D for flexor digitorum longus, and H for flexor hallucis longus. The tibial nerve and posterior tibial vessels also pass posterior to the medial malleolus between the tendons of the flexor hallucis longus and the flexor digitorum longus. If you want to include these structures in your mnemonic, it turns into Tom, Dick, and very nervous Harry. A for artery, V for vein, N nervous for nerve. Remember that this mnemonic only goes into effect at the level of the medial malleolus. These structures are in different orders in the leg and in the foot. The medial and lateral heads of the gastrocnemius, the soleus, the plantaris, the popliteus, the flexor digitorum longus, the flexor hallucis longus, and the tibialis posterior are all innervated by the tibial nerve. Blood supply to the leg is provided entirely by the popliteal artery, which bifurcates into the posterior and anterior tibial arteries in the proximal part of the posterior leg. The anterior tibial artery passes laterally and anteriorly and pierces the proximal part of the interosseous membrane to reach the anterior compartment of the leg. It travels in a neurovascular bundle with the deep peroneal nerve and the anterior tibial vein between the tibialis anterior and the extensor hallucis longus muscles, and changes its name to the dorsalis pedis artery upon crossing the level of the malleoli. The posterior tibial artery continues through the posterior compartment of the leg alongside the tibial nerve. It gives off the peroneal artery, which runs laterally and inferiorly and sends branches to, but does not enter, the lateral compartment of the leg. Veins draining the deep portion of the leg run with the arteries and are named accordingly. The wide network of subcutaneous veins, running in the fat between the skin and the crural fascia, drain into two main superficial veins, the great saphenous vein and the lesser saphenous vein. The lesser saphenous vein begins at the lateral end of the dorsal venous arch on the foot and runs superiorly along the posterior aspect of the leg until it dives into the popliteal fossa to drain into the popliteal vein. The great saphenous vein begins at the medial end of the dorsal venous arch and runs superiorly along the medial aspect of the leg and the thigh until it passes through the saphenous opening of the fascia lata to dive into the femoral triangle, where it drains into the femoral vein. The superficial veins drain the skin and the fascia of the lower extremity and communicate with the deep veins via perforating veins. The nerves providing cutaneous innervation to the leg are the saphenous nerve, the sural nerve, and the superficial peroneal nerve. Recall from the solid anatomy lecture on the thigh that the saphenous nerve is a branch of the femoral nerve and thus originates in the lumbar plexus of nerves. The saphenous nerve travels in the adductor canal with the femoral artery and vein, but unlike those vessels, does not pass through the adductor hiatus. Instead, the saphenous nerve continues medially and pierces the deep fascia at the level of the knee to become subcutaneous. It passes down the medial side of the leg with the great saphenous vein and innervates skin on the medial 2/3 of the anterior side of the leg and the lateral 1/3 of the posterior side of the leg. The sural nerve is a branch of the sciatic nerve that often originates in two parts, one from each division of the sciatic nerve. These two parts may remain independent, or they may combine to form a single sural nerve. The sural nerve runs with the lesser saphenous vein on the posterior aspect of the leg and innervates skin on the lateral 2/3 of the posterior side of the leg and the lateral 1/3 of the anterior side of the leg. After the superficial peroneal nerve provides motor innervation to the peroneus longus and peroneus brevis, it pierces the crural fascia at the distal end of the lateral part of the anterior side of the leg and innervates a small area of skin superior to the malleoli. It then continues anteriorly to supply cutaneous innervation to most of the dorsal surface of the foot.
So that covers the lecture on the leg and ankle. Now I want you to pause the video and answer the end of session quiz questions, and then we'll go through those answers together. All right, let's get going. First question. Which nerve is responsible for cutaneous sensation of the medial aspect of the leg? That's going to be saphenous nerve. Next question. Which main nerve gives off nerve branches responsible for the cutaneous innervations of the lateral aspect of the leg? That's going to be the sciatic nerve. Next question. Which fascia of the leg is continuous superiorly with the fascia of the thigh? That's going to be the crural fascia. Next question. What position is the foot in when it is dorsiflexed and when it is plantar flexed? So dorsiflex means that the foot is pointed up. Plantar flex means that the foot is pointed down. Next, what is the muscle that unlocks the knee joint from full extension? That's the popliteus. Next, which muscles form the triceps sura, which gives rise to the Achilles tendon? That's going to be the gastrocnemius muscle and the soleus muscle. Next, which feeble muscle in the leg has an extremely long tendinous insertion? That's going to be the plantaris muscle. Next question. Where does the patellar ligament attach to the leg? Now remember this structure from the clinical correlation is the area of the tibia involved in Osgood-Schlatter disease. That's going to be the tibial tuberosity. Next, which artery becomes the dorsalis pedis artery when it crosses the extensor retinaculum? That's going to be the anterior tibial artery. Okay guys, we're almost done. We provided some images again for you to label. Recalling these images in a time setting will help you perform well on your practical part of your examination. So label the images and then we'll be finished. Thanks.